All right, welcome everybody to the call. I'm going to now hand it over to Dr. Huntsman to welcome us and get us started.
So, welcome everybody, and we're here to talk about a major breakthrough which has come from our OVCARE ovarian cancer research team, and to celebrate International Women's Day. And I think that this is an appropriate way to celebrate. I'd like, before I start, for us to acknowledge that we are presenting and working from the unceded lands of the Coast Salish peoples, and in particular the Musqueam, Stolo, Tsleil-Waututh, and Stizimous nations. I'd like to tell you a little bit first about how OVCARE formed. And 20 years ago, Dr. Diane Miller, who's on the call today, called together all those who were interested in working on ovarian cancer into a room and said, basically, she was sick of seeing women die of this disease. And perhaps if we work together, we could make a difference. And that conversation or meeting seeded a partnership which has flourished in ways we couldn't have imagined. We first built resources to encourage other researchers to engage in ovarian cancer research, and then started working on the problem. The first thing we did was to realize and to discover that the ovarian cancer isn't a single disease as it was treated in the clinic and studied in research labs, but it was actually a series of distinct problems, all of which need distinct solutions. That's created a blueprint for how ovarian cancer is managed and researched internationally. We then discovered the key mutations which underpin most types of ovarian cancer, and those findings have become diagnostics and are being developed as targets for treatment by our team and groups around the world. And then something happened along the way. We realized that you can't really study ovarian cancer without considering uterine cancer and other gynecologic cancers. And so with Dr. Gavin Stewart's leadership, we formed something called the Gynecologic Cancer Initiative. And we've all coalesced around a vision that if we work hard together, we can decrease death and suffering from gynecologic cancers by 50%. And this will be done through work in prevention, diagnosis, through management and clinical trials, and of course, survivorship. Within our team, we now have global leading programs in the development of classification tools to help decision-making for women with endometrial cancers, led by Dr. Jessica McAlpine. Tremendous work going on at Children's and Women's and the BCCDC on cancer of the cervix vaccination programs for HPV, and a nascence program led by two recent recruits here, Dr. Amy Jameson and Dr. Lynn Hong, and others on cancer of the vulva. None of this could have been accomplished without a series of partnerships which have underpinned everything we do. So we all work together, we share a vision. We work across institutions and with multiple institutions, including, of course, the Vancouver General Hospital. We work with the population of BC. Whatever we do has to count for everyone if we're going to achieve our mission. And in particular, we are tremendously grateful to women who've received the worst news that you can possibly receive, that you have one of these cancers, and they almost invariably respond with an act of tremendous generosity and let us study their tumors, and their tumors get put in our tumor bank, which is based in the Vancouver General Hospital. We also work with the foundations, such as the VGH and UBC Hospital Foundation, and they provide the fuel which allows us to get going, and then we bring in funds from peer-reviewed national and international competitions to drive our research forward. But we couldn't get moving without the foundations and, of course, all of you. And I hope that when you listen to the presentations today, and that you will share our pride, because this wouldn't have happened without you. So around 20 years ago, when OVCARE formed, it was believed still at that time that ovarian cancers came all from the ovary. And then a series of studies, which we contributed to but didn't lead, came out which showed evidence that these cancers probably don't come from the ovary. They either come from the fallopian tube or sort of pass through the fallopian tube before they become a cancer. And the rest of the world was quite excited about this, and everybody responded to it in the same way, including, I must say, myself, where we thought, how can this help the 20% of women who have BRCA1 and 2 mutations who and with ovarian cancer. But Dr. Diane Miller's response to this information was unique globally. And she asked the question, how can we use this information to help every woman who's at risk for ovarian cancer? And she then thought about it and said, well, if fallopian tubes are where these cancers come from or pass through, let's start removing them. And she coined the term opportunistic salpingectomy and developed this ovarian cancer prevention program. Sometimes when somebody comes up with an idea which is simple, or when you look at it after the fact and becomes adopted internationally, we can lose track of how brilliant and unique that idea was and how powerful it was. And we're here to celebrate today what that idea has done and the results we have, which shows that Dr. Diane Miller was right, and we can prevent a large number of the ovarian cancers which occur around the world based on her idea, which is a simple idea. The implementation is simple and possible, and it's going to be profoundly impactful. And it wouldn't have happened without you. So now we're going to get to the really exciting part of this. We're going to hear from Dr. Diane Miller first. Dr. Diane Miller is a BC native. She's basically revolutionized the care of gynecologic cancers in BC through her incredible leadership of the British Columbia's Gynecologic Cancer Tumor Group. She's acknowledged around the world for her efforts in developing the ovarian cancer prevention program, opportunistic salpingectomy. She was a co-founder of OVCARE and was the driver and connected us with the community and fundraisers and allowed us to really get going. She has been recognized for notable achievements and many awards, including the VGH and UBC Hospital Foundation's Lifetime Achievement Award and the Women of Distinction Award from YWCA. When we recently met as friends who work with gynecologic cancers to talk about Diane's legacy, the one word that resonated to capture how we were all feeling about her career was the word hero. And so it's a great pleasure to introduce Diane Miller to you and ask Diane a question. So you came up with this brilliant idea for opportunistic salpingectomy. How did you turn it into clinical practice?
I'm just going to unmute. And first of all, if I appear to be blushing, David, you've made me blush. I think that what you stated at the beginning is really true, is that this is it was a really simple idea. And I think what it reflects more than anything is the importance of scientists working with clinical people, because you're quite right that people became very focused on BRCA, but myself, the greater part of my career has been spent treating women and doing gynecological surgery. So it was inherently obvious to me that we had been doing some of those surgeries incorrectly for at least my entire career. We had, as a standard rule, left the fallopian tube with the ovary as opposed to taking it out with the uterus. And once we found out that the high-grade serous cancers, the most lethal and deadly ovarian cancers, started in the tube, it just seemed obvious that we should be taking out the tube. Now, things seeming obvious is great, but we did, one of the things you didn't mention is we did get a lot of pushback from a lot of different centers. One of the pushbacks that we got was you would never be able to implement this in clinical practice. And one thing that's very unique about British Columbia is the gynecologic oncology community has a special relationship with the practicing gynecology community. And every year we have a meeting where we get together with the practicing gynecologists and update them on what's going on in gynecological cancer. When we presented the opportunistic salpingectomy to the practicing community of gynecologists in British Columbia, the uptake was enthusiastic and rapid. And within a very short period of time, we went from taking the tubes out with hysterectomy less than 5% of the time to over 85% of the time in a couple of years. This has allowed the research that Jillian's going to present today, because she's going to have be able to present on a large number of women who underwent an opportunistic salpingectomy. as part of their routine gynecological care. And I'm just going to end my one little part of this presentation by saying what I always say when I give a talk, is that curing cancer is amazing, but never getting it in the first place is even more amazing. And one of the problems with prevention is it's very hard to get people enthusiastic about something that never happens, where when somebody gets the cancer, you're immediately engaged in that cancer community. And I think from a fundraising standpoint, and I'm not a fundraiser, so I can't really say this, I think prevention is a harder sell because you don't really have the advocates on the ground because they didn't actually get the illness to develop that connection. So I'm going to turn it back to you, David, just with that reflection.
Thank you, Diane. And we're going to look forward to getting your responses to some questions which we've received. Next, I'd like to introduce Justine Greene. Justine was there on day one when we announced this program in the Vancouver General Hospital, and I know some of the audience were there as well. And Justine very graciously agreed to speak to this program and its potential, and was on the cover of the Vancouver Province and was featured in many newspapers and has been an eloquent spokesperson ever since. So Justine has an extensive background in nonprofit leadership and systems expertise. She oversees operations at Callanish, which is a nonprofit of a multidisciplinary, dedicated team of professionals who create healing spaces and immersive programming for people and families whose lives have been impacted by cancer. After losing her mother, Virginia Greene, grandmother to ovarian cancer, Justine continues to be a passionate advocate for ovarian cancer prevention and will share her story today. Justine, I wonder if you could tell us about the decision process you went through in 2011 and now reflect back on how that may have impacted your life and the life of your family.
Well, thank you, David. And hi, Diane. It's so nice to see you. So nice to see you. Thank you for inviting me to join this conversation today, as I feel that it's part of my legacy is to say yes when you guys call. And so I say yes. So I'm happy to be here and share my little bit of the story. As David had mentioned, back in 1962, my grandmother passed away of ovarian cancer, but in the 60s, it was the silent C word. So it wasn't what we actually thought as a family. My mom had thought it was colon cancer. So the story got bigger as time went on, but that was in the 60s. So in 2009, when my mom was diagnosed with ovarian cancer, Virginia, we went through her treatment, and it wasn't until after she had passed away, of course, we did some genetic testing for my sake. And after she passed away, that test came back that there was no BRCA, but as Diane had said, she had had a high-grade serous type of ovarian cancer. And because of my grandmother's story, and at 52 when she passed away, and my mom at 66, those are young women in definitions of cancer. I learned back then that the recommendation from Diane, I remember exactly where I was when Diane phoned. And why Diane had my results, or at least maybe I'd flip them to you, Diane, and ask for some feedback. And I remember exactly where I was when Diane called and said, so, you just did this research. So in 2010, you're right, I was a poster child on the cover of both papers, which was ridiculous. I think it was supposed to be my mom, and she was alive, and she said to me, it's your turn. It's your turn to be the spokesperson for this. And I took that with honors. And so when Diane called and I said, well, here are the results, what do you think? And she said, well, it's up to you, but here's the research that you've just been part of learning about, and what do you think for your life? And I was 39 at the time, and I'd had my son, and I finally wasn't having any more children. And it seemed, it's funny, I think this is almost an irresponsible word to say, but it seemed like a no-brainer. It really seemed like this story for my family had to end. That's two matriarchs in our family dying of this disease. Like I said, we didn't know my grandmother was, so my mother wasn't on a watch list because they thought it was colon cancer back then. But the geneticists at the cancer agency were able to do the research, which was fabulous. So now we actually knew a family tree, which was important for me. And I remember sitting in the lobby, I think I don't know, I remember exactly where I was in a building downtown and having this chat with Diane and just saying, I just don't think there's another option. And I hadn't gone into menopause yet. So Diane said, well, keep your ovaries and we'll talk about that when that kicks into gear. But for now, let's get your tubes removed. And within a couple months, I think, maybe even a month or so, don't quite remember, thank God. It was 11, 12 years ago. I had my tubes removed, and it was a no-brainer. It was a simple procedure. Felt like I'd done 1,000 sit-ups, which I've never done in my life. So that was a new feeling. But after that, I had removed, I think at the stat back then, it was like 96% of ovarian cancer was on the tube. So I felt at that moment that I had saved myself from this disease by 96%. That's a big percentage, and it was a huge relief. The last thing I'd want is my son to go through what I had gone through and my mom had gone through. So it just felt the responsible thing to do. And, there were some interviews back then of, well, what if we find out that your tubes are useful in 30 years? And I said, well, same as tonsils. What if we find well, I'll deal with that in 30 years. Like if this is a safeguard for me for the next period of my life, then it's the responsible thing to do. So that sort of answers, I think, your question, David, of the why.
Thank you. And I mean, presumably, you might sometimes reflect on the fact that if you hadn't had this done, what you might have had to face.
Well, I know enough about cancer because, of course, it's in my career now too. But the date I was working toward was the younger age in my family. It wasn't my mother's age at 66. My grandmother was 52. So the closer I was going to get to 52 and having this cancer in my life, the clock was ticking louder. And so, it sounds a bit heroic, I think, this word, but I don't know what else to say. I feel like I saved my life. And yes, something else could get me, of course, and it will, and it could be a different type of cancer, and I can't control any of that. But the one that was facing me, and then of course, when I was 45, I had my ovaries removed because I went into menopause. So I feel like I've just dodged a huge familiar genetic, non-genetic for testing, but advancements will come when time comes. I feel like I dodged a bullet. So I feel very grateful. Like I literally feel that maybe I'd be alive still, but I feel like I'd be waiting for the bomb to hit or the clock to, whatever analogy you want, if I hadn't had that done. So I don't have a sleepless night about it. It was the best thing to do for my family and my son.
Thank you, Justine. And we'll look forward to getting your perspective on some of the questions which we know will be coming. Next, it's a great pleasure to introduce Dr. Gillian Hanley. So Gillian is a Tier 2 Canada Research Chair in Population-Based Gynecologic and Perinatal Outcomes. And to be a Canada Research Chair is a great honor. And I know that when Gillian was being considered for this, her application was at the top of the pile. She's an extraordinarily successful researcher. She's an assistant professor in the Department of Obstetrics and Gynecology at University of British Columbia, a Canadian Institute for Health Research new investigator, a Michael Smith Foundation Scholar, and a Janet D. Cottrell Foundation Scholar. Her research focus combines her substantive interest in women's health with her training in economics, health services research, and epidemiology to answer questions related to gynecologic cancer and primarily ovarian cancer prevention and survivorship, as well as healthy reproduction and pregnancy. We're very blessed to have been able to recruit Gillian into our team. And as the sort of senior research leader, it's my job to make sure that the incoming researchers who expand the capacity of our team to embrace this mandate of reducing death and suffering from gynecologic cancers by 50% are superstars. And Gillian is such a researcher. So I know that Dr. Hanley has some slides to share on her recent publication, which it provided a result we expected, but we needed to see it. It shows that Diane's brilliant idea from 2010, it works. And so this may seem like a small piece of data, but it can change the lives of so many women and families around the world. So at this point, I'd like to introduce my colleague, Dr. Gillian Hanley, to you all. And Gillian, if you would like to grab control of the screen so you can share your slides, that would be wonderful.
Okay, thank you so much, David. Does that look right, or do I need to flip the display again?
You still need to flip the display.
The display, thank you. Better?
Good.
All right, thank you. Having double monitors makes this tricky. So thank you very much for having me. I'm just going to go through the research and try to explain exactly what we discovered recently around the effectiveness of opportunistic self-injectemy. And this slide is really just, cartoon of the anatomy here to just be clear about what we are talking about when we say opportunistic self-injectemy. So opportunistic self-injectemy is the complete removal of the fallopian tube, which you see here. And as we've discussed, there was increasing evidence that a lot of high-grade serous ovarian cancers originated in that fimbriated end of the fallopian tube. And so when we talk about opportunistic self-injectemy, we talk about taking advantage of surgical opportunities to remove the fallopian tubes in order to prevent ovarian cancer. So the purpose really is prophylaxis. And we have been doing this at the time of hysterectomy, which is removal of the uterus, here highlighted, being removed right there. And also instead of tubal ligation, which is commonly referred to as having one's tubes tied for the purpose of preventing any future pregnancies. And so Diane's recommendation back in 2010 was to include self-injectemy at the time of hysterectomy, so to completely remove the tubes at the time of hysterectomy, and to completely remove the tubes rather than ligating them in people who were seeking permanent and irreversible tubal sterilization. And also, as Diane alluded to, we had tremendous uptake in British Columbia following Diane's recommendation, and this really speaks to her leadership. We actually did some research around why people were so enthusiastic about changing practice, and Diane's name came up many times that, they really trusted Diane as a thought leader, and if she asked them to do this, they believed that it was the right thing to do. And so you can see that in 2008, we only had about 8% of people undergoing hysterectomy had their tubes out at the same time. And by 2017, this was up to 80%. And this is in people where ovaries are being left behind. So we don't want to remove ovaries for ovarian cancer prevention because of the hormonal implications. So to remove ovaries prior to menopause can increase long-term consequences like increased risk of cardiovascular disease and osteoporosis and other conditions. So we really do want to leave those ovaries behind, as Justine mentioned as well. In younger women in particular, women under 50 or 55 in particular. And so at the time of sterilization, we really weren't doing self-injectomies at all in 2008, but by 2017, 3/4 of people who were requesting tubal sterilization were having their fallopian tubes removed. So this is really, really remarkable practice change. There's a number that gets thrown around with respect to knowledge translation often, which is that it usually takes 17 years for something to be seen in clinical practice, for an idea to translate into a clinical practice change. And clearly it did not take anywhere near that much time here. And again, that really speaks to how trusted Diane was as a thought leader in British Columbia and the great relationships that were developed between the OBGYNs and the gyne-oncs in the province. And so we've spent a lot of time in the last 8 or 9 years studying opportunistic self-injectomy in British Columbia. And so we understand a lot about its safety. So we wanted to make sure, of course, first off, that there was no increased risk associated with removal of fallopian tube during these other surgeries. And so we've done a lot of work to show that there is no increased risk in perioperative adverse events. So things like length of stay in the hospital, readmission, blood transfusions. There's no increased risk in minor complications, things that would sort of occur outside of the hospital post-discharge. So visits for surgical infections or complications, or additional imaging being ordered, or additional lab tests. There was a slight increase in filling prescription analgesics, but that had completely disappeared by 1 month post-discharge. So no indication that there's a problem there. And there's also no evidence of reduced age of onset of menopause among people who had their fallopian tubes removed. So that was the concern that Diane discussed thoroughly with Justine, and we have increasingly reassuring evidence that fallopian tube removal does not decrease the age of onset of menopause. And practically speaking, it doesn't take significantly longer in the OR. It's about 16 additional minutes at hysterectomy and about 10 during tubal sterilization. But the main thing that we want to talk about today is whether or not this works. So are women who've undergone opportunistic salpingectomy less likely to get ovarian cancer? And this is the first evidence of effectiveness for prophylactic opportunistic salpingectomy that has been published. And again, we're able to do this here in BC because we really were world leaders. So, you know, that dramatic uptake that you saw, so many women now have had opportunistic salpingectomy in BC, and they've been getting it since 2010. So we're able to have enough follow-up to start to see this difference. So what we're showing here is that we calculated how many ovarian cancers, specifically high-grade serous or any epithelial ovarian cancers, that we would have expected to see in the opportunistic salpingectomy group if they were arising at the same age-adjusted rates as they were arising in the control groups, which are people who got hysterectomy alone, so had a hysterectomy but their tubes were not removed, or people who had just a tubal ligation, so their tubes were tied but not removed. So we just used the rate that cancers were developing in those two control groups to calculate, based on the follow-up time that we had in our group who had undergone opportunistic salpingectomy, how many cancers we should have seen in that group if there were no differences in the rate of cancers. And what you can see here is that we should have seen about 5.3 high-grade serous cancers in the opportunistic salpingectomy group, and we saw none. So there were 0 high-grade serous ovarian cancers in the group of people who had undergone opportunistic salpingectomy by the end of our follow-up period, which is very exciting. And I'm not allowed to share the exact number with respect to epithelial ovarian cancers because my privacy agreement that I've signed with data stewards says I can't share numbers between 1 and 5. But I can tell you that it was significantly lower than we would have expected. And again, this number here that we would have expected is 8.7. And so we wanted to examine whether this might be explained by differences in risk and protective factors for ovarian cancer. So maybe these groups of people differed in ways that we know are important in influencing the likelihood that they'll get an ovarian cancer. And could that explain why we were seeing fewer ovarian cancers in the opportunistic salpingectomy group? So we looked at data here for those common risk and protective factors in these groups. And so here you can see how many people we're looking at here as well. So we had 32,080 patients who had had an who had had a control surgery, so a hysterectomy alone or a tubal ligation, compared to 25,889 who had had an opportunistic salpingectomy. So we've got nice big numbers of groups here. And what you can also see here is that in all the ways that these groups significantly differed, which is the purple numbers here, it actually serves to increase risk for ovarian cancer in the opportunistic salpingectomy group. So these people were older, they had had fewer live births, which increased number of live births is protective against ovarian cancer. They had had fewer pregnancies. Again, even incomplete pregnancies are protective against ovarian cancer. And they had a higher rate of endometriosis, which is also a risk factor for other forms, not high-grade serous, but other forms of ovarian cancer. So all of these common risk and protective factors can't explain why we're seeing significantly lower ovarian cancers in that opportunistic salpingectomy group. And so then we thought, well, could it just reflect that the people in the opportunistic salpingectomy group are somehow less prone to cancer in a way that we can't measure in our data? And to examine this, we did the exact same calculations that we did with high-grade serous cancer and epithelial ovarian cancer, but we did it for breast and colorectal cancer. And what you can see here is how closely these expected and observed numbers of breast and colorectal cancers are here. So we expected 22.1 breast cancers and we observed 23, and we expected 9.35 colorectal cancers, and we observed 8. So clearly, again, this isn't explained by group differences in the likelihood of getting cancer in general. So all of this really serves to increase our confidence that what we're seeing with the lower numbers of observed ovarian cancers is in fact a result of the opportunistic salpingectomy that those people had. And these numbers are really small because our data only extended to the end of 2017. We are in the process right now of getting more up-to-date data, but because we work with these large population-based administrative data sets, there's always a bit of a lag time. But if we project out to the number of cancers that we would have expected by 2022, it's 36.87, and by 2027, it's 45.1. So the number of prevented ovarian cancers is just going to keep increasing with time because these groups of women are still quite young, and the average age of diagnosis of ovarian cancer is 61. And so while these preliminary numbers suggest, a small number of lives saved, this is just going to continue to increase as we follow these people out in time. And then, of course, we're also continually adding more people to that opportunistic salpingectomy group as well. So people are getting opportunistic salpingectomies in British Columbia every day. So we're adding more to that group. And we also have some recent national data that shows that while BC has really been a leader in terms of uptake of opportunistic salpingectomy, that some of the other provinces in Canada have lagged behind a little bit. And again, these data are a bit old, so we're working again to update these. But you can see here, this is proportion of all hysterectomies, which is why these numbers are different. So it includes hysterectomies where bilateral salpingo-oophorectomies, so both tubes and ovaries were removed. But you can see BC has the significantly highest rate compared to these other provinces, and that opportunistic salpingectomy at tubal sterilization has definitely lagged behind. So a lot of provinces are still doing not as many as we would like to see of these. And unfortunately, we calculated that there was there was exactly 179,219 missed opportunities in the 5-year window that we looked at across Canada. And if you assume a lifetime risk of about 1%, which is probably a little lower than an actual lifetime risk, and if you assume that about an 80% effectiveness of opportunistic salpingectomy in preventing ovarian cancer, this is going to result eventually in 1,400 ovarian cancers that could have been prevented if this opportunity had been taken. And so what is next for this research? We are actively working right now to expand the opportunities at which we are consenting and asking women to undergo salpingectomy at the same time. And so right now we're working on a trial looking at opportunistic salpingectomy during colorectal surgery, because colorectal surgeons are in the pelvis, they have ready access to the tubes and are really well trained in laparoscopic techniques. So it seems like an obvious next step. We're also actively doing national and international outreach to try to increase those rates of opportunistic salpingectomy across Canada. And then also we have a project right now working with colleagues in Kazakhstan to promote and understand how often opportunistic salpingectomy is happening there. We're also speaking at the Eurasian Congress of Gynecologic Oncology to talk to all of them about opportunistic salpingectomy. So really working on reaching more low and middle income countries. And then also studying and improving the impact post-implementation. So David's probably the best person to talk about this, but he and I are starting work on an ovarian cancer observatory where we will be collecting tumors that arise post-salpingectomy and post some of these other surgeries so that we can better understand if and when high-grade serous cancers arise in patients post opportunistic salpingectomy, sort of how do those cancers differ and what makes them unique. And this will allow us to extend prevention efforts and hopefully ultimately to understand how to prevent as many ovarian cancers as possible. And I just, again, wanted to thank all colleagues. This is not a complete list of colleagues, but many colleagues who have, this is team science, as David mentioned. So there are so many people who've been a part of all of this work. And of course, all of the funders and the foundations and the donors, all of you who have donated to this work. It's been incredibly instrumental and we couldn't have done it without you. So thank you very much.
Thank you, Gillian, for your presentation. So I wonder if I could address a question first to Diane and Gillian. And so in the past, we've shown that opportunistic salpingectomy is safe, but now we have the evidence that it works. What will that mean in terms of uptake across the rest of Canada and international?
Gillian, I'll take the first crack at it because I've been fairly passionate about this for a long time, but I do believe now it should be considered unethical for someone to discuss having a hysterectomy with a woman and not discuss potential salpingectomy as part of that procedure. And I think it also borders on unethical for the same reasons with tubal ligation. Gillian didn't mention that we're also talking to people about other gynecological procedures, for example, ovarian cystectomy, which is quite a common procedure. And if it's occurring at or after childbearing, that's another opportunity to take out the tubes. So I think it's becoming clear that true informed consent has to include a discussion of this. And I do believe that women, being incredibly intelligent as a group of people, that will improve uptake further.
Thank you. Gillian, would you like to add to that?
I mean, I agree completely. I think there were people who were really waiting to see some preliminary effectiveness data. And, I hope now that it is out there and that it is accessible, that we'll start to really see increased uptake. And I agree that it should be part of a conversation with every person who is having a hysterectomy and every person who is asking for tubal sterilization. And we hope that, also some work that we're doing is trying to have more conversations with GPs because they do a lot of the contraceptive counseling. And so even just for this to be part of that discussion so that, couples are going to make choices about what makes the most sense for them in terms of contraception, but they should also know that opportunistic self-injectome has this additional benefit of preventing ovarian cancer.
And I mean, I also agree that whereas before this evidence came out, a clinician could always say, well, there wasn't evidence this worked, and now there is. So modern practice and modern legally defensible practice must include a discussion of this procedure. And I mean, Dr. Hanley showed, there's still, even though in BC our uptake is very strong, across Canada that is not all the case. That's not the case, and it's horrifying to think there were so many women who could have had their ovarian cancers prevented, and it just wasn't done. So we must stop that from happening in the future. There's some questions that are coming in the chat, but also there were some questions which we'd received earlier, and some of those include. Maybe I'll go to Diane first. You formed OVCARE and you stimulated its formation 20 years ago. What would you like to see OVCARE achieve in the next 10 years?
Oh boy. I think that there's been such an interesting evolution of what our expectations were when we started OVCARE to what actually happened. And I think at the beginning, our expectations were probably fairly modest, in line with a lot of other cancer programs, where we just wanted to have more people surviving and et cetera. But what I think, where I think OVCARE needs to go, and I think it is going in that direction, is really understanding two things. I think the prevention is one big bucket that is critically important, but I think there's still going to be people that, women that get gynecological cancers, and particularly ovarian cancer. And I think what we need to do is continue to sort of interrogate these tumors, find out what mutations are driving them, and work towards individualized treatment that's going to result in better outcomes. We're already starting to see the beginnings of that, and some of the novel mutations in that have been discovered in OVCARE have real potential going into the future to make big differences for women. And I think in terms of women getting the cancer, that's really the road forward. I think the other thing that we've learned over the years, which you alluded to at the beginning, David, is that it's hard to understand ovarian cancer in isolation without looking at other gynecological cancers, particularly other upper genital tract cancers, both uterine and indeed even cervix to a degree, because both the uterus and the cervix less likely can be the source of ovarian cancers. And I think really understanding what's going on in these fallopian tube, uterine and cervical cancers within the ovary will have an added benefit of providing novel treatments for other gynecological malignancies, and ultimately result in improved survival for the individuals, as well as overall improved survival for the population as a whole.
Gillian, would you like to address this?
I mean, I have a lot of sort of, there's a lot that I would like to see in terms of improvements in processes to make doing the kind of research that we want to do easier, but that's not really up to OVCARE necessarily. But no, I mean, I agree with what Diane said. I think continuing to expand prevention opportunities to make sure that we do not miss an opportunity to prevent an ovarian cancer is really important. And that, goes beyond just the OBGYNs. So talking more with general surgeons and making sure that every single opportunity that can be taken to prevent an ovarian cancer, that every patient has that discussed with them. So that is really important to me. And then, of course, continuing to understand how all of these different gynecologic cancers, operate together, understanding how we can better prevent other forms of epithelial ovarian cancers as well. So, the endometriosis associated ovarian cancers are also in theory preventable. We just don't yet have all the information that we need to know how to do that most effectively. So I also want to see a lot more work done there. And then the work that we're proposing to do with the ovarian cancer observatory David, is so important as well, because we still don't know how many high-grade serous ovarian cancers actually originate in the fallopian tube. That's still a question that we don't have an answer for. And I think that we'll get the answer within the next 10 years. And that's going to be really important to progress our understanding about all forms of ovarian cancer.
I've been extremely inspired by our gynecologic cancer initiative and the way that it takes the teamwork, which has underpinned our successes as OVCARE, and just expanded our horizons into decreasing death and suffering from all gynecologic cancers by 50%. And that's changed everything we do. It means we have to consider all gynecologic cancers and work together. So we didn't have work going on in cancer of the vulva, and now we have a team which is formed, which works with us and takes the things we've learned in ovarian cancer and brings them in to address another problem. We have to study prevention through to early diagnosis, treatment, and survivorship. And we didn't have the clinical trials capacity or leadership to take the ideas we were developing and make sure that women in BC benefit first. And so we worked with UBC and we got funds to recruit an amazing clinical trialist from the UK who's going to really propel us in this space and allow us to lead in clinical trials and provide mentorship for others who will become clinical trials leaders themselves. And then in survivorship as well. When we look across all gynecologic cancers, this is a big need. And we have a clinic which has been built to support survivorship research, and we want to see more clinical trials in that space. It also, we basically didn't have the team to deliver on our mission. And so it allowed us to strategically identify gaps and bring people in, give them space and freedom to operate and build their careers. And it's been amazing to see how some of our junior colleagues have done. And lastly, this larger mission, it isn't possible without partnerships with the entire population of British Columbia, because we want women in BC to benefit first. And we can't achieve this 50% reduction in death and suffering unless we make it count for everybody. And the partnerships include the foundations and the funders of our research, and also, of course, the donors who work with the foundations. And so we were really grateful that you could join us here today. Some of you might have been there when this program started, and the foundation took a chance on OVCARE when it formed. And I believe that we're proud of what we've accomplished. I hope that you as supporters are also proud of what we've accomplished. And we're very grateful to have been given the opportunity to do this work. So it's really exciting. I mean, I always knew teams were important, but I never knew the power of teamwork until Diane presented the opportunity to work with OVCARE. There are some other questions. Let's see, so here we have, at what age is opportunistic salpingectomy recommended? Maybe Diane, you can.
Yes, so I think that's a really important question, because I think the age is decided upon by the woman who's undergoing the procedure. And, I don't want to get into put on my feminist hat or whatever, but I think that women are quite capable of knowing when childbearing is complete And if childbearing is complete and they're undergoing a gynecological procedure, I think it's entirely appropriate for them to have the discussion about opportunistic self-injectomy, be they 21 or be they 62, okay? So I think it's really a decision that's made based on life events that are going on, but no gynecological procedure should be performed without a discussion about that. One of the things that Jillian didn't expand on that I'll just expand on is, you know, at hysterectomy, there really wasn't much pushback because when the uterus is gone, the tubes don't really have a purpose. Tubal ligation caused a bit more of a pushback, but, and one of the pushbacks was, well, what if the woman wants to get her tubes reversed? And to all intents and purposes, nobody gets their tubes reversed anymore. In vitro fertilization has basically replaced reversal of tubal ligation because it works better. So there's not really a loss, any more of a loss of fertility by having your tubes removed as opposed to a tubal ligation. So the youngest person that has requested a tubes coming out, to my knowledge, was a 25-year-old. And it's probably younger than that by now. I think it really is dependent on the woman's lifetime wishes. So women can make that decision when it's appropriate for them.
So we have one more question because it's such an important question. And that is opportunistic self-injectomy recommended for all women or only women with a family history of ovarian cancer? That's a very important point to get straight. So Diane?
The short answer is all women. We know that all women have a lifetime risk, slightly over 1%, about 1.3% chance of getting an epithelial ovarian cancer in their lifetime. The inherited predisposition, the women who have an inherited predisposition, it's about 25 to 40% chance, so order of magnitude higher. But the real beauty of opportunistic self-injectomy is that it will prevent cancers in the non-hereditary population, and it can only do that by economy of scale. So the more women that have an opportunistic self-injectomy, the less epithelial ovarian cancers we're going to see. So it does apply to all women.
Thank you. So at this point, I'd like to thank you all for participating today. I hope you learned something, and again, we're very proud of having reached this point with opportunistic self-injectomy and taking Diane's brilliant idea and showing how this works. And we believe that this is going to turn thousands of women around the world from people who would have been diagnosed with and potentially died of ovarian cancer into women who never knew they were at risk. And nothing can be better than that. I'd like to thank the funders for our research, which include the granting bodies in Canada, the Canadian Institutes for Health Research, Canadian Cancer Society, Michael Smith Foundation, and others, BC Cancer Foundation, and of course, VGH and UBC Hospital Foundation, who always do a fantastic job of organizing these events. And I'd like to thank Imara and her team for looking after us so well and bringing you all here to meet with us today. And lastly, thank you all for attending today, and I hope you've enjoyed this, and would like to again say thank you for supporting our work.